So I just want to review some facts about the guidelines. We talked about these CPT codes. There they are again, in case you want them. If you go to the CEUS website, there is a phenomenal chart that has all of the billing, and I think there was a copy in the room with the vendors that goes through all the different codes and the different, depending on what kind of institution you are. So I recommend you at least pick one of those up before you leave. So there are both from World Federation of Ultrasound and Medicine Biology and EFSM, European Federated Societies of Ultrasound and Medicine guidelines. They are both for liver, and there's one for non-hepatic uses. The WFM guidelines are going to be updated later this year and should be out. They're very good. They're quite lengthy, but they review all of the literature and provide you a lot of information that we can never give you within a one-day course. So there's the things there. The ACR, AIUM, SRU practice parameters for ultrasound and contrast is in progress. The ACR appropriateness criteria, they were not listed in the previous version in 2014. These are in the process of being updated, and we're hoping that we have CEUS added for abdominal applications. The SRU recommendations for CEUS in the North America are almost finished, and I hope to have them submitted and published by the end of the year. So what's really critical is this ACR appropriation criteria, because the new rules are when you order an exam, you have to order something that's high on the appropriateness criteria list. So it's very important that we get CEUS added into them. We have not had much luck to this point, but we're hoping that at least in the next version, we'll get them in for several applications. And again, it's kind of critical because if you order a CEUS and it's not listed in the appropriateness criteria, you're not going to be able to order it in many of the EMS systems. So again, ICUS, I think, is going to have a big part to try to get this into these criteria. We've got a couple people that are CEUS experts into those committees that are doing this, so hopefully we'll have some better luck. If we look at the practice guidelines for HCC diagnosis, they're listed here. And the one that concerns us is the AASLD, American Association for Study of Liver Disease. They still do not use CEUS in their guidelines. In Canada and in Europe, in Japan, Korea, and the EFSM and World Federation guidelines, yes, but EASL, no, either. So we still have a little bit of work to do for that. And I think our foot in the door is probably going to be in patients that can't get CTRM or contrast, probably should get a CEUS, and we're hoping that those practice guidelines would include that, at least for that exception, that everyone should have a contrast study. I don't want to go over these in great detail. These are the AASLD guidelines in 2011, and they recommend, again, what to do with a liver nodule. But again, no CEUS. So hopefully those people that are involved in this society will help to get CEUS added into that. And the reason that AASLD does not endorse CEUS is they feel like, number one, they don't have enough literature. There's no specialists with CEUS in the committee, and they feel like we need much more literature in an American population. And since Stephanie's in Canada, she doesn't count as an American. So again, we have a lot more work to do to get these into these guidelines. I do want to go over some of the literature. There was a meta-analysis by Friedrich Rust that looked at a huge number of cases, and she included 45 studies looking at focal liver lesions, and ultrasound contrast had a sensitivity of 93% and a specificity of 90%. And these were compared to CT and MR, and the sensitivities and specificities actually were quite similar between CEUS and contrast-enhanced MR and CT. Here's the meta-analysis. And again, I'm not going to go over this in great detail. I'm sure these are projecting quite small and you can't see, but there are a large number of papers and all show that we do quite well in terms of characterization of liver lesions compared to CT and MR. And again, looking at just HCCs, again, the pool sensitivity actually was much better for CEUS versus CT and MR. If we look in the literature and compare ultrasound contrast versus contrast enhanced CT, there are 3 papers that directly compared in the same patient these things. Now, the first one by Quea, really, we're not going to talk too much about because it's kind of not fair. He only took patients that were indeterminate on CT and showed that in those patients, 89% accuracy for CEUS. And I think Stephanie has brought this out, that, CEUS is very good when CT or MR are indeterminate. In a large number of cases, ultrasound contrast would do that. But if we look at the remaining 2 studies that compared head-to-head the same patient, you can see that the sensitivity of CEUS in both studies was better, and the specificity in both studies was better. If we look at ultrasound contrast versus MR, there were 3 studies done. And again, in 2 of the studies, the sensitivity of CEUS was better, and the specificity in those 2 studies was better for CEUS than MR. In the other study, they were about equivalent. So we think all of the literature suggests CEUS is as good as enhanced CT or MR. Again, in terms of guidelines, LIRADS is out there. It continues to evolve. Obviously, there's CT guidelines, MR guidelines, and ultrasound contrast guidelines. Again, I think Stephanie went through this, and we're not going to go in great detail. And in your handout, we have a lot of handouts, including that. And it works quite well. But again, as Stephanie has highlighted in her last talk, this is really to only be applied to patients at risk for HCC, so those patients with chronic liver disease. Are we getting the data? So there are several studies going on now. There's one multi-center trial that Andrei Lenchek is leading that has an international collection of data to try to support CEUS in terms of the LIRADS and trying to get it into these organizations. These are the participating sites. I assume that it's going to be at least a year or so before they have results. So the take-home message is ultrasound contrast. There is a specific CPT code for abdomen. It's here. It saves money and is cost-effective. It also saves time and a quicker diagnosis. I think Ed Grant has a paper that I think is included in your packet where he showed at the community hospital where it's months to get a CT or MR. He's able to answer a large number of these questions with ultrasound and get the patients through the system much faster and at a cheaper cost. And again, we really hope that we can get into the ACR appropriateness criteria because this is very important because now with these new EMRs, if we don't get it in, it'll be almost impossible for physicians to order CEUS. It looks like CEUS will be added to the appropriateness criteria, but our rating, and again, it's the rating that's really critical. How good is it? Because all of the techniques are ranked, and again, if you don't pick one of the top 2 or 3, then you're going to have to explain why you want this test done through the ordering system. And again, the majority of societies are endorsing CEUS for hepatocellular diagnosis, except the American Association for the Study of Liver Disease. So any questions? So we have a ways to go, and I thank Linda and ICUS for pushing us to try to get into these things and get awareness in the community so that we get these guidelines. And like I said, our biggest problem with doing livers is our oncologists feel uncomfortable because CEUS is not in the normal workup that's recommended, and they feel there's medical legal issues if they don't do what is in the recommended workup. And it's about 2:30. Yeah.
So We know, Richard and I do, that in the center in the United States where the patient, where the person who's the president of the AASLD resides, that they have suggested not only that you should never have CUS, but additionally that you should do surveillance MR scan for looking for HCC. And what, do you want to make a comment?
Well, like, some of those articles are based on screening. I mean, we're using, we're supposed to be using characterization, not screening and surveillance. We're using it for screening and surveillance.
No, so there's two issues, obviously. One is surveillance, and then the other issue is characterization of what you find. And so the LIRADS group they've done a lovely effort on that, on the surveillance. And so when it's the surveillance scan, then you end up classifying it basically as it's positive. You think there's something that's concerning that you should do a contrast enhanced examination. You're uncertain, or else it's negative. And so my own personal feeling, and our population is obviously very, very similar to yours. You know, I don't know if you noticed that, but on the cases that I showed you today, virtually every case that comes to us has had an outside ultrasound. Not every case, but virtually every case. And so that, plus the fact that we do surveillance ultrasound. So we have clinics that we've tried to limit now. So in Calgary, there's a lot of private practice of ultrasound. So we've tried to limit the number of clinics that do surveillance scans. And we've tried to really insist that they have the best equipment, that they don't have just any old ultrasound machine, and that the techs that do it are really devoted to it, and they do all of the multiple planes and look really carefully. And so I personally can't fathom that there's anywhere, there's nowhere in Canada ever that will ever do MR scan for surveillance. I mean, if you need an MR scan, if you're dying, you have to wait till you're virtually on death's doorstep to get an MR. And so you're certainly not going to have one for doing surveillance. And I think that that's the most ridiculous thing. I just can't fathom that they would suggest that. So that's one issue. But then the other issue is that the AASLD makes the recommendation that nodules that are found on surveillance ultrasound should be characterized with MR scan. And it's intuitive in my mind that it's better to solve the surveillance ultrasound issue with ultrasound. And this is not related to the patient who has a nodule that turns out to be an HCC or that turns out to be a cholangiocarcinoma. It's related to the patient where a perhaps inexperienced technologist, or the combination of different things, where they suggest that something might be real, and it's actually a pseudomass. Like, it's either related to fat or it can be related to different things. So resolution of pseudomasses. And then the other thing that happens too is that, I'm sure you've all seen this, is like we get sent a patient that's got a nodule supposedly in segment 2. So when we do the scan, we don't find a nodule in segment 2, but we find another nodule that turns out to be an HCC. Well, see, if you're not quite meticulous about how you report that, then it ends up going back to the clinic that, oh, that patient had a positive surveillance scan and they had an HCC. Well, when it's an HCC in a different location, so misregistration and pseudomasses and those kinds of things, they're better resolved by ultrasound. And so I think it should be surveillance with ultrasound, then CEUS, and then there will be some patients that will end up going to MR scan, and all of the ones that you say have HCC will end up going for MR because they require them to be staged before they can be treated if they have HCC. And so I think that that would be better, but there are people that are so incredibly adverse to inclusion of ultrasound and inclusion of CEUS. It's very difficult and distressing, I think.
Yeah, and we're trying. Yes.
What is their opposition just to including the contrast and ultrasound as a protocol? What is their, I don't understand, what is their hesitancy to do so, just to do a one-year study to see?
I think the argument is that they feel that there's not enough literature to support putting it into the guidelines at this point in time.
Okay. They want to be included in a generating study to help.
Correct. So I think that there are studies now going on that are going to try to answer this question. I think ASLD is not setting up these protocols. They're just saying, we need them. So I think other people are out there trying to set them up to answer the questions.
But there are people who hate ultrasound. Just by the way, if you haven't noticed that, there are other people that even hate CEUS more than ultrasound. But, having said that, the quality of what we do is so important. And so, for example, I'm just was astonished, when people get up and talk about how terrible surveillance ultrasound can be. And so you have to really run ripshod over the places in your geographic domain that do say that they offer surveillance ultrasound, because you can't just go in and take, an 8-minute scan and whip across the liver with one probe and then say there's nothing there. You have to really, really look. And a lot of people just they're not interested. And if they're not interested, in my mind, I don't know why they don't take their toys and go home, but they don't. And so they stay out there and they continue to make big, problems for us. But I don't know what will happen. But I do think like the worldwide standard is to do surveillance ultrasound. And that's proven itself to be good in Asia and in Europe. And I mean, that's all that we use. And I mean, we find so many HCCs. I mean, maybe we miss a few HCCs here and there, but we would know about them if we were missing them in my environment, because then they would be back 6 months later for another scan. And so, of course, everybody has skeletons in their closets. So cases that we find where I think we should have called that on the last scan, or we should have done things, somewhat differently. But it's such a very, very important thing. And that's why I showed that preamble information about HCC. I mean, this is a big problem on this continent now. And also, when I think back in my own practice, 20 years ago, I never ever would say to a patient, we think that you have a liver cancer, and that patient never had any history of anything. Whereas now, it's a regular occurrence that we see, particularly heavy women who have HCC, and that's the first time they ever hear that they have anything wrong with their liver. They haven't been told they have fatty liver, they haven't been told they have cirrhosis, they're not going to the metabolic clinic, but they have a very fatty and abnormal liver, and they have HCC. And Richard knows, so in Canada, we don't have an obsession with billing codes. And that's why we don't do enough. We don't get paid enough, or we don't do enough. But like if I see a patient that has a liver mass, I immediately do a elastography of the liver, because it's important. I can't report it accurately. I can't. When I get into that dilemma: is it LRM or is it non-hepatocellular malignancy? And those dilemmas are killer. And so we can do an elastography, and I can.
So what she's talking about is doing elastography to prove that the patient has chronic liver disease and at risk for HCC.
And we can do CEUS also. Like I don't ask anybody to do it, to have a requisition. And so I know it will never get that way in the United States, will it?
There's one sneaky way of doing this that can work, that we use for actually doing breast workups, is that you can ask the referring doctor to send a script in that says ultrasound abdomen limited or complete, ultrasound contrast if indicated. So then it gives the radiologist the option if he can use it, but you're going to have to get your referring doctors to write the script. So when we have a diagnostic breast case, we've got everybody trained almost that says, diagnostic mammogram, ultrasound if indicated, biopsy if indicated. So then we can do whatever we want to do or we need to do at the one setting. We haven't gotten to that point. I think a couple places in the U.S. that have an EMR have actually put, ultrasound abdomen and then underneath contrast if indicated, and they just click that box automatically. So the default is they can do ultrasound contrast if indicated. So again, these are the kind of the ways around that. But, you know, on our, we don't have an EMR, we just get paper scripts. It's again educating. So if I need to do this, then I have to call the doctor, ask them to forward another script that says ultrasound with contrast. And half the times we can't get a hold of the doctor or whatever. So then it turns out into a multi-day process as opposed to a simple get it done immediately.
Like, I haven't asked the doctor if I could do something for 30 years. At least that long.
Yep.
Within cardiology, we have a default with the order of cardiac grant, it's indicated what we contact.
Right, and that's kind of where we need to get to in our system.
Referring physicians have no input.
But how did you get there?
We talk to the hospital, talk to the administrator, and we don't send patients back and forth. In our opinion, after imaging the patient, we see contact, we are given the authority to go ahead.
So totally agree, but that does not seem to be the philosophy in the abdomen. Would you agree?
Agree. But I mean, like you said, that is a legal option for us. It just hasn't been used, and we need to get to that point. And again, I think part of the same thing is if it's not in the ACR appropriateness criteria, people are saying, well, why would you want to do it anyway? So I think if we get these into the guidelines, if we get them into an option, then, you know, these things become a little bit easier to get through hospital committees and administrators.
So I'll make another comment as well. So, you know, like over the time, I guess at this meeting and then also other meetings that we've just been at recently, a lot of times when people get up to talk about CEUS, they make the very first reason why they should do CEUS is renal failure. And so I already said in my own talk, I showed, we did a prospective study and we showed how sensational it is for that, just sensational. But see, I would never get up and say that's why I'm going to do CEUS. Like it is a reason why I do it, but that shouldn't be the reason. We want people to believe that those CEUS LIRADs.
No, and I agree, but I think that the one way that you could get AASLD to agree to some contrast is to say a CT without and an MR without contrast is not sufficient. And a CEUS in those patients would be beneficial. And then at least you get your foot in the door, and then you can go from there. But getting your foot in the door sometimes is the thing you have to do most of the time. Yeah.
Are the surveillance scans being ordered based off of HSC or FSX, or what are the surveillance ultrasound? How are they being ordered or why?
Any chronic liver disease. So for us, it's actually a lot of NAFLD patients, in
So-
addition to the hepatitis.
So in most geographic regions of North America, they do the same thing. So they tried to make on a geographic basis like a registry of all of the patients who they believe are at risk. And so herein comes the thing about how do you pick up the patients with NAFLD, and from the metabolic clinic we miss them. Like they end up coming, they're more advanced than we think that they are. But nonetheless, they try to make a registry, and then the objective of the registries is that we know that those patients do need Q6 monthly surveillance. And so, of course, the patients who fall off of the registry, if you leave it to the patient's motivation, are patients with chronic hepatitis B who have a normal liver. So they have HBV, their carrier status at risk, and they're told over and over and over that they should always come for surveillance. And I tell every patient that I see like that, I will see you in 6 months, and I don't let them go until they're looking right at me and nodding that they're coming back in 6 months. And so they want the registry then to make the appointments for them. So then the registry actually phones and says to them, it's the same as carcinoma of the cervix, you know, between PAPs tests and mammograms. There's lots of those kinds of things, and this falls right into that. And so then they want them to be on the registry and to absolutely make sure that they have their scans. And so then again, as I said, they don't want them to have them all over the place. They want there to be recognized and kind of registered facilities that actually do surveillance scan. And so that's what we do where I am. And so do I do some surveillance scans? Sure. We do lots of them, but we don't do that big bulk, like the masses of them. That's the same as the patients that have query metastases. Those are big numbers of patients. And most ultrasound facilities wouldn't want to be doing, like case after case after case, that surveillance scan. But it's a big and important thing. And so the LIRADs for that as well, for surveillance, they're very, very good. Like, they really tell you what don't do this, don't do this, don't do this, do this, do this. They're good. So would everybody like to have a coffee break?
Question? Yep.
Yes.
Good.
Well, so no washout has a suggestion, an inference that this is quite possibly a benign lesion. But first of all, the original statistical evidence was that washout suggests malignancy. And so you would think that you could say that the reverse would be true, that no washout suggests it's benign. And so although it does suggest it, it does not have the same degree of statistical validity. And so that is because, so when you take, if we had talked about it more today, if you have a nodule that enhances, it's 1 centimeter and it enhances, and then it just doesn't wash out. So this is where it comes in the question with cholangiocarcinoma, and that's why cholangiocarcinoma is often indeterminate on MR, because many HCCs enhance on MR and then they never wash out. They just don't wash out. And so they're often well-differentiated lesions. And so over time, they might start eventually to wash out. But so sustained enhancement has a tendency to benignancy. And if it has all those other features, like those stellate vessels and peripheral puddles and pools, you can be sure they're going to be benign. But in a patient at risk for HCC, no washout doesn't have the same inference that it's benign. Oh, at least 5 minutes. Yeah. No, and for sure. Well, in fact, when Peter Burns and I started to do this, we used to get beautiful scans. I showed you even on those old ATL ultrasound machines. But the thing is, we would inject the patient, and then we would do the 30-second, the 60-second, and the 90-second scan. And then Peter says to me, and then we'd go for coffee. And while we were gone for coffee, they'd wash out, and we would miss it because we were no longer looking. And so we were one of the first groups that said, you got to watch longer, because I became aware of the fact that although I felt like we were doing so well, I'm totally and madly in love with what we do myself. So I was so impressed with how well everything was going. But then when I started to get pathology back, I realized that we were making mistakes. And so it was when we came to look at why were we making the mistakes, and almost all the mistakes were on HCCs where we had terminated the scan at 90 seconds, thinking that was the end of the scan. So we didn't know when we started to do CEUS that you should watch for 5 minutes. So we made every mistake you could make. And then now we've written guidelines so that you don't make them. So when you get out there, you won't make them because we already made them for you. But so sustained enhancement is good, but not like washout.
Any other questions? So it's almost 3 o'clock. You want to take a 15, 20-minute break? And then we can come back and we can do some cases or answer any other questions that you have and wrap things up. Is there anything that we haven't talked about that you would want us to talk about? If so, let us know at the break. Yes. I have not, and I doubt that Stephanie has either, but
So when I go to a meeting in Germany every year, and there's a lovely lady there who's a pediatric radiologist in Hanover, and she's started to do pediatric cases a long time ago, like 15 years ago or more, and she has a very, very, very nice collection of cases. And now, since the FDA has approved a bubble in the United States, I'm absolutely astonished how quickly and how nicely several centers, mostly in oncology, heavy oncology patients, how well they've done doing CEUS. But my opinion, which won't be the same as yours because you're a pediatric imager and I'm not, But my opinion about the pediatric cases that I've done myself, and so when I was in Toronto, CEUS was right across the street. I told you that before. CEUS was right on one side of the street and I was on the other. And so we did, I don't know, 25, 30 cases of children with liver masses. I never wrote that up. I never collected them. But basically, I would just look at them and I would think how much we were giving to an adult, and I'd give less. And when you're only using 0.2, how much less can you give? Like, so it would either be 0.1, a 0.1 was usually what we gave. And really and truly, children don't have the same incidence of liver masses as adults. And in addition, they don't have the same spectrum of pathology as adults. But no, I have no hesitation for you to start to do it. And for trauma for children, it's sensational. Okay?
Okay.